The following podcast is part of a certified educational activity titled Evolving Methods for Precision Care in IBD Management and Targeting TL1A. Access the entire activity and complete the post-test at peerview.com/WVY860. Downloadable slides and practice aids are also available.
Good morning, everyone. It's a pleasure to see you all here, bright and early in the morning. I'm Bruce Sands from Mount Sinai in New York, and it's my distinct pleasure to be here with my good friend and colleague, Dr. Marla Dubinsky, also from Mount Sinai in New York. And we're here to give you a very interesting presentation, and we're focusing on precision care and IBD management, and also talking about targeting TL1A, a very interesting new target and mechanism of action for inflammatory bowel disease. So what do we want to accomplish today? We're going to talk about the limitations of the early paradigm of reactive symptom-driven management of IBD. This is not the way we should be treating patients in this day and age, and we're going to try to talk about the benefits of the treat-to-target approach in these patients. We're also going to talk about the application of precision medicine principles for both diagnosing and monitoring IBD. And especially we're going to focus on the use of biomarkers as a way of guiding individualized treatment decisions. And some of these we actually have and use now, but others will come to us in the future. And finally, we need to talk about emerging strategies using a very new target, TL1A, as a therapeutic target in IBD. And we're going to talk about its mechanistic rationale and show you the mounting clinical trial evidence that supports this MOA as an exciting new direction for the treatment of IBD therapy. So, again, I'm Bruce Sands from Mount Sinai, and I'm going to set the stage with just a couple of slides here and just look backwards a little bit and consider that 27 years ago we had no biologic therapies whatsoever, we had no anti-TNFs, and this clearly was a revolution in the care of patients with IBD. And all the subsequent progress that we've made with anti-integrins, JAK inhibitors, anti-IL-12 and 23s or IL-23 inhibitors, and the S1P receptor modulators have brought us along, able to treat more and more portions of the IBD patient population in better and better ways, also with improving safety, I would add, over time, and this is all remarkable. But we still have many unmet needs in IBD management. We're still evolving in our diagnostic and monitoring strategies. One of the key things is we don't make early enough diagnoses, and we know that the earlier we diagnose and the earlier we treat, the better. So we need better diagnostic strategies, and we're not that great in monitoring our patients. Often we're just seeing them in the office, waiting for them to come back for a 6-month or 1-year follow-up. We don't know what's going on in between. Maybe they'll call us when they're not feeling well, maybe they won't. So we need new strategies, both invasive and maybe non-invasive, hopefully less invasive, and we need to optimize the frequency of that monitoring. There's another kind of way in which diagnostics will help us, and this includes predictive biomarkers, and that means who's going to respond to what therapy. Evolving management paradigms also include been talking about this a long time, but a top-down approach instead of stepping up through different therapies, getting to the most effective therapy early, treating to specific targets, not just treating to symptoms, thinking about newer targets, not just mucosal healing, but actually transmural healing, and evolving new patient-reported outcomes that are important to patients. And finally, therapy selection and sequencing, because we know that often it's trial and error. We'll try a medication, they don't respond, we move on, and we often, even with the medications we have, as good as they are, we can't get the patient easily to achieve a deep remission, and of course we want to minimize safety concerns. So we've come a long way, but we still have a long way to go in IBD. And with that, I want to turn it over to Marla for a talk on moving toward more proactive management of IBD.
Thanks, Bruce. This seems to be the theme yesterday at the IBD session, talking a lot about where are we going in terms of monitoring and how do we really start to get drug treatments early on in the treatment pathway for patients and really be able to practice a more treat-to-target proactive approach to actually not waiting for people to flare before acting, not waiting for people to lose response before acting, and all that comes with the proactive treat-to-target approach. So I think, one of the key fundamental problems we have on IBD really is that we confuse disease activity with disease severity. It's a construct. I mean, all of our drugs are approved for moderate to severely active IBD, either UC or Crohn's. What does that mean? That means at that point in time, I have symptom activity, I have endoscopic activity, plus or minus histoactivity, and I take nothing into account about what has happened since the diagnosis until that moment, and taken into account any type of precision prognostic indicators that suggest this person or this individual has a more severe prognosis. And so I think part of it, this has been preaching for a very long time, the ability to say that really what we should be able to do is actually look at the individual characteristics of that patient and choose treatments accordingly. Don't just look at how many APTHI or what the SCSCD score is to make a decision if this patient needs advanced therapy or not. That concept is really important. As I noted, where we want to go really is to be able to say, what are the principles of being able to determine which patient is high risk of complication? In Crohn's disease, it's fibrostenosing, it's penetrating disease complication, the need for surgery, ulcerative colitis, hospitalization, steroid dependency, and really, poor compliance of the colon. There are factors that we could do today that actually identifies patients before they have severe disease, and really, as I noted, identify patients at risk. So there's been a plethora, and some folks are in the room who have been in this space for a long time, with myself as well, since I was a fellow, it was just yesterday, but since I was a fellow, looking at what are really some of the prognostic indicators, be it clinically, serologically, genetically. Are there various ways that we define severe, meaning a patient who's going to have a more complex chronic course? And the reality is, when you look at Crohn's disease, by definition, other than limited anatomical extent, this chart means that every patient with Crohn's disease should be on an advanced therapy. That's what this chart is basically saying, that there are very few characteristics that render a Crohn's patient not at risk of needing advanced effective therapy. Ulcerative colitis, there's a little less in terms of our ability to stratify, but these are the factors that have been published both by the AGA as well as this paper from the group at Sinai, sort of looking at how are we bucketing patients into a more mild versus more severe phenotype. Now, why does that matter? Because we have seen over time that despite, Bruce, you showed that slide of an incredible expansion, and if you look at it even in UC over the last 3 years, just when you see the immense expansion, why are we not changing the natural history of these diseases? We have incredible therapies to a point where, as we're getting new therapies, there's a higher bar to reach because we've got really good therapies. The problem is we're waiting until someone declares themselves severely active and then say, yeah, you need an advanced therapy. And that concept of reactive care, even in the face of treatment decision-making, is impacting the natural history. The natural history, particularly of small bowel Crohn's disease, is if you're not going to give me an effective treatment, I'm going to lay down collagen. This is me talking like the small bowel, laying down collagen and developing progressive damage over time. That is the natural history of Crohn's disease, particularly in the small bowel. If we are not able to avoid that, patients are still going to go to the OR. And what this graph really continues to show, and this becomes a graph that, as we know, we have seen multiple years since publication, really the idea is that we need to act early and act appropriately and effectively if we're going to change this trajectory. And that's sort of the concept of really treating beyond just symptoms. Why is that important? Particularly in Crohn's, I think the SONIC trial really told us that 50% of patients in the SONIC trial, which, as you remember, was combination thiopurine plus infliximab versus infliximab alone versus thiopurine alone. And guess what? You didn't need an endoscopy to get into the trial. The endoscopies were read virtually in Belgium, and 22% of people who met the CDAI criteria of active disease had 0 endoscopic ulcerations. So up to 1 in 5 people that entered that trial did not have active IBD. but symptomatically they had active IBD. And further, at the end of SONIC, to look at what combination looks like, 50% of people who would have failed based on an activity index saying, I don't feel well at all, I'm very active, had a normal scope. And conversely, patients who say, I feel terrible, I feel fine, I'm sorry, their scope was very abnormal. So Crohn's disease, you can't rely on symptoms alone. It's really important for us to understand the biology of these diseases. Typically in UC, if you do have rectal bleeding, chances are pretty high that you have active inflammation. It doesn't say the extent of the inflammation, but you've probably got, at minimum, some proctitis, right? So we rely a little bit more on symptoms in UC, but really in Crohn's, we have a big problem. Now, what did the CALM trial supposed to do? The CALM trial was saying, stop just waiting for people to declare themselves symptomatic to optimize and escalate your therapy. There was 2 arms in this study whereby you were able to escalate adalimumab to weekly as well as add combination based on when a patient says, I don't feel well, versus the other arm which said, regardless if you feel perfect, but you have an abnormal calprotectin or CRP, I am escalating your therapy. So that is using objective biomarkers to decide that my patient is going to become symptomatic, even if they're not symptomatic, and their bowel wall is going to progress with more damage. And what that showed at the end of the year is that indeed, people who don't wait to declare themselves symptomatic to escalate and just use objective biomarkers, regardless of symptom resolution or not, and you had a significantly higher number of those patients meeting the STRIDE target of endoscopic healing or remission at a year. Now, glass half empty, half full. 50% of our patients didn't reach that endpoint. That's a whole symposium on its own, is why are we not getting people to achieve these endpoints? Is that where combination comes into play? Is that where optimization comes into play? We really have to think about why only 50% of patients achieved endoscopic or mucosal healing despite being optimized. So other things we know from this same study, a follow-on to the CALM study is the following. If we took both arms, we don't care who got that endoscopy score of perfection and then followed them, whether they got there through the optimized based on biomarker versus optimized based on symptoms, as long as you reach that target, what happens to you over time? And what this is basically saying is that individuals in a treat-to-target strategy that we apply in practice, if patients are not achieving within that year of starting an advanced therapy, switching to another therapy, whatever the concept of starting an advanced therapy in that patient is, that you significantly see increased rates of complication, surgeries, need for steroids, flares, hospitalizations in patients who are not treated to an endoscopic target. And that's basically what this study is showing you. The significant long-term outcome, and for those of you who've heard me say this, is that IBD is not a week 52 disease. It is a lifelong disease. Stuff doesn't change on day 366. And so it's really important that we understand we need to get people in depth of remission. And this is sort of that another famous picture, which is our STRIDE, which is from the International Organization for Study of Inflammatory Bowel Disease, IOIBD. STRIDE 1 was published in 2015, where we said, make sure symptoms are better, short-term goal. Everyone wants people to feel better. But we can't stop there. We must go to biomarker remission that we added in 2021, actually, in the first iteration of STRIDE 1. We didn't have CRP and CalPro. And then the CALM study came on and said, oh, no, you better actually optimize based on CRP and CalPro. STRIDE 2 took what I just showed you from CALM, put that in our guidance. You don't have to scope people. If their CalPro or CRP is up early, treat and optimize. Use that as a sign that this patient is not in remission, and the ultimate target is to improve quality of life. And we felt as an organization, in order to change quality of life, as you saw from the CALM follow-on, is you must get to as deep as remission as you can endoscopy, right? That's sort of where we are in that STRIDE. And STRIDE 3 is currently being planned, so you will see the next iteration. And on the right, it talks about where we're going from a formal target, transmural healing, and histohealing. You're like, oh my God, I got to think about more things at this moment. But yes, we will be bringing not too far from now, actually what STRIDE 3 will be focused on is, can we do better And have we reached a therapeutic ceiling? Because we are not striving for the right target. Particularly in Crohn's disease, it's a 4-layer bowel wall, right? And we're only looking at the inner mucosa. We never have actually treated to a transmural outcome, which is what we're proposing as being the next stage. We'll have to see. Bruce and I have a little tiff around this, is that can you actually get there? Good question. He's always very thoughtful in his questions to me. What happens? Are you actually going to optimize and change therapy if you don't have a perfect bowel wall? That'll be next year's symposium.
We'll see.
We'll see. And histology is the other for UC, not quite in Crohn's. So these are what you're probably going to see as future targets that we're going to be bringing, hopefully, in our STRIDE guidance. We'll see what the literature says, and we'll see what the consensus is. So the reason why my sort of thought process around transmural comes from this permeation of lots of different studies that are percolating, looking at the role of transmural healing as it relates to endoscopic healing and what that looks like over time. And if you look at need for hospitalization, need for surgery, it is very clear that when a patient reached transmural healing, they had 0 surgeries. So there's reason why we believe for Crohn's disease, transmural needs to be the outcome, whether it's MR versus ultrasound, that's up for debate. But at the same time, this newer study came out and said, I'm going to take it even one step further. I'm going to compare the various levels of remission we talk about, clinical, CRP, calpro, endoscopic, and histo. Which one is transformational in the outcome of surgery and hospitalizations? It is transmural remission. Again, making the point that we are not measuring the right thing and continue to ask the question, why are the surgery rates not coming down at the rate that we need them to come down? I think this is sort of the key message in Crohn's disease. And we've also seen this differentially in another survival type analysis looking at endoscopic plus radiologic versus no healing, obviously, worst outcome, versus absence of both or just one of. And you could see when you have endoscopic plus radiologic, look at the natural history of the outcome for our patients. This is what we need to strive for, right? This is what patients expect from their treatments. So again, it's really about us sort of stepping up our game and bringing novel treatments, and Bruce will talk about TL1A. Just as a side note, there's a lot of buzz about intestinal ultrasound and point of care. Bruce, I think I unleashed a beast when we brought it to Mount Sinai during the pandemic. And sort of now it is spreading like wildfire. Our European colleagues have been doing this for a very long time. And it's sort of just become newish, a new toy, a new skill set in the clinic, in the IBD centers, and some community practices. But people will often ask me, is ultrasound as good as MRI? And the literature actually states, yes, ultrasound is as good as MRI. So that is why there's an evolution to really start to apply intestinal ultrasound at the bedside to be able to make treatment decisions. And I believe that that is the next CALM study, which is not just biomarkers to escalate, but also based on intestinal ultrasound. You will be optimizing, and hopefully that becomes part of the STRIDE 3 guidance, an early marker of disease activity as opposed to a disease outcome. It can do both. And then Mike Dollinger presented that at the end of the day, you can even, when I talked about can you bring it in earlier to the process and use ultrasound when you normally do a post-induction CRP or calpro, put a probe on the abdomen. And what you can see is that if you already have a bowel wall thickness that is less than 3.6 post-induction, you're going to have a normal endoscopy at a year. So really, I think we're getting better in understanding. The other thing that we need to start to understand as we bring intestinal ultrasound to clinical trials. This was one of the first. This was Stardust, which was ustekinumab, a treat to target using every 4-week ustekinumab. One of the things that we know is that the terminal ileum is one of the hardest parts of the bowel to treat, which is why even transmural outcomes with ustek were not very good in the ileum. And so we must think about, do certain drugs work better in one location or the other, and start to be much more sophisticated about personalization of treatment. And so this was another newer one that our friends from Israel, Shomron, put together saying, you can also think about capsule as a treat to target. They do a lot of capsule. That's what Shamran sort of grew up teaching us around capsules, but also showing that you can use capsule endoscopy as another treat to target modality, and you actually saw a significant decrease in flare if you use the capsule to help optimize treatment. So sort of where will capsule fall in our new guidance? We'll have to see. And one of the things that's really important is at the end of the day, when we look at putting way back in 2008, this top-down versus step-up is sort of nonsense, turning the pyramid upside down. Who are you going to treat effectively and go, just kidding, I'm now going to give you a mesalamine in a Crohn's patient? So it's really early effective intervention. And even I think the study, the title was going to be like top-down versus step-up, and the title got changed to Early Effective Combined Approach, which was in 2008 saying, listen, if you have a patient that you're either going to do a typical step-up, wait for them to be sick, wait for them to be steroid failure, then add a biologic versus just going straight up biologic from that moment, who do you think does better? Obviously, someone who is given an approved therapy. Remember, in Crohn's disease, there is no approved maintenance therapy other than an advanced therapy. There is no approved therapy for maintenance of Crohn's disease, which means every Crohn's disease patient needs to be on an effective advanced therapy. Profile, double down. So here we are, a study that said within 15 days, if you put somebody on this step-up sort of thing, or you put them on combined thiopurine plus infliximab within 15 days of diagnosis, and you look at the orange versus the blue, you don't need much explanation. Bottom line is, I don't care which drug you use, Profile used infliximab, that's not what the point of the discussion really is. It's to say, please use something that is approved and effective for both induction and maintenance, and do it as close to diagnosis as possible. That's really, I think, the message about where we need to go. So here's the case, Bruce. So Mark, 27-year-old, diagnosed with left-sided colitis 2 years ago, initially prescribed topical and oral 5-ASAs with prednisone, has been on oral 5-ASAs on maintenance, and was doing well until about 8 weeks ago, where he started to have a recurrence of symptoms. He had required, as we see often, sort of this pulse of prednisone without sort of advancing, right? This is just a patient, oh, you're unwell, take your prednisone, use some rectal therapy, call it a day. And so presents Mayo endoscopic score of 2, CRP that's elevated, normal limit was 5, SED rate 31, and a CalPER of 782, with normal being, or let's say for the purpose of this, less than 250. Is presenting with rectal bleeding, increased stool frequency, abdominal pain, discomfort associated with a bowel movement, relieved after a bowel movement, and really wants to know, what are my therapeutic options? So, how would you assess disease activity and severity in this patient? Like, what's the summary here, and what do we need to think about?
Well, activity is right here before you. I mean, he has already had an endoscopic subscore of 2. That means there are breaks in the mucosa. He has symptoms that are bothersome to him. Typically, we're going to talk about rectal bleeding and stool frequency. We don't have mention of urgency, but I can guarantee he has that as well. Fatigue, lots of other things. He has inflammatory biomarkers in case we didn't believe the Mayo endoscopic subscore. So he's there. That's the activity. The severity is that he's required 2 courses of prednisone in 2 years. That is too much. And so you can say from any perspective, he has to move on to another therapy, an advanced therapy, no question.
So what treatment option would you recommend for him at this time? How do you make this decision? Because don't you get asked all the time, like
sure.
Walking down the hallway?
Well, there's so many choices, right? So
yeah.
It's no longer an algorithmic choice. You don't just go down a flow chart and say, oh, this is the drug, because you want to take into appreciation what the patient wants, what their personal characteristics are, what match that with the characteristics of the speed of onset of efficacy, the absolute efficacy, the side effect profile in relation to the risks that the patient may have. Here, this is a young man. He's an active guy, probably. We don't know what he does for a living, where he is in his life. but he probably wants something convenient. We want something that's as safe as possible for him. There are a lot of great choices for him. I mean, historically, it might have been an anti-TNF. That would be wonderful. But these days, we probably have safer choices. Any of the, we could use ustekinumab, we could use any of the anti-IL-23s. We could certainly use vedolizumab. That would be safe. But these are parenteral, and if he preferred an oral choice, we would use an S1P receptor modulator. All of those would be acceptable choices.
So we talk a good game around treat the target and how many of us actually apply it into practice.
Yeah.
So this patient, he just had an endoscopy. You're about to start him. How do you monitor success in a patient like this?
So certainly I'm monitoring his symptoms. You know, that should change first. And I am also monitoring often the fecal calprotectin. In our office, because we have intestinal ultrasound, that's another thing that we can use along the way to monitor. It's very convenient. It's point of care. I don't do it myself, but we have many people around us who can do it. Ultimately, I am going to rescope the patient. In this day and age, somewhere for UC 4 months, outside 6 months, I'm going to rescope, and I really want to see that ideally he's going to have a Mayo endoscopic score of 0 if I can get there. I will take biopsies and look at the histology. I'll consider whether I incorporate that into my decision.
I was going to ask you, what if patient is macroscopically gorgeous, Mayo 0, but does have, some chronic active chronic active colitis. Today, are you adjusting therapy? Patient feels great.
If the patient is not symptomatic, I'm not, but I'm very wary because I know that patients like that are at risk for flaring again symptomatically in the year. So I'm going to keep a close eye and monitor that.
So in a patient like this, which is very common, this is like what our patient, what walks in, what type of patients walk in. Is there anything today? Question on precision medicine. Is there anything precise about what you have in our hands today? We'll talk about the future in just a second. You're going to wow us with what we got and what we're looking forward to in the future. Is there anything today that tells us anything about precision for this patient?
It depends on what we mean by precision. If we're talking about prognosis, we can make general statements about prior use of steroids and so on. And that is, to some degree, personalization, their characteristics. But I think mostly when we think about precision medicine, we're thinking of, is there a test I can send off that's going to tell us how the patient is going to do prognostically? No, there is not. Is there a test that we can send off that's going to tell us which drug type, which mechanism of action the patient's going to respond to? At this point, there isn't. So we're going to shift gears a little bit and talk about precision medicine in IBD and talk about where we are and where we may be going with personalization. If you think about how we practice medicine now, we have a bunch of patients. They come through our office. We treat them with a drug, and then some people respond. Some people don't respond. Other people will get side effects that limit their ability to take the medication, but we can't really tell who's who. The idea of the future idea for precision medicine is that we have a tool or a lens that's going to refract this population in a way that we can sort them before we treat them, not trial and error. Sure, we want the ideal strategy, a top-down strategy that is part of ideal treatment, but wouldn't it help to be able to prognosticate? If we knew someone was guaranteed to have indolent disease for a long time, maybe we wouldn't do a top-down strategy for that person, applying extra risk for that sort of patient. So prognostic precision tools would be helpful, but I think a lot of us are really waiting for the kind of diagnostic that is a predictive biomarker of response to a specific therapy, treatment A for this patient, treatment B for that patient, treatment C for the next patient. And that's the holy grail. Right now, it's one of the potentially 3 ways in which we're going to get out of this therapeutic plateau that we're seeing. One way could be a novel mechanism of action. That's a killer MOA. It's really so profoundly effective. But short of that, precision medicine may help us. And we're not going to talk about this today, but combination therapy could also be of assistance. So where are we with the precision world in IBD? Well, the promise of genetics has been out there for a long time. I won't say that we're disappointed with genetics. We've learned so much about what may be contributing to inflammatory bowel disease, but there are well over 200 genetic polymorphisms that contribute to the risk of IBD. Each one of them contributes a tiny, minuscule amount of risk. But if you add these up in a polygenic risk score, that actually shows you some additivity of the genetic variance in terms of the risk. And if you do that exercise, it does work to some degree. The area under the curve is not great in terms of what you would want for a diagnostic. It's only 0.63, but there is some information in that. I don't think this is ready. This is a research tool. It's not something we're using in the clinic right now. Marla actually was a pioneer on the use of serologic markers that could actually prognosticate for an aggressive course of Crohn's disease. Of course, you've heard of all these serologic markers, ASCA, anti-CBER, anti-ANCC. These are all antibacterial serologies, interestingly. Tells us another thing about what causes the Crohn's disease. And the interesting thing is that when you applied quartile sum scores to these different antigen-directed serologies, the more of these that you were positive for, the more likely that you were going to have an aggressive course of disease, penetrating disease, stricturing disease, surgery. And so you could think of a way in which you might incorporate this early in the treatment of your patient to identify someone who has an aggressive course of disease. And some people do that. What about proteomics? Well, this is from the risk cohort, which is a pediatric cohort, where they did sampling of serologies and all kinds of other kinds of sampling at baseline, right at diagnosis, and then followed the kids out to see who developed complicated disease behavior. And you can see that if you looked at proteins only or serologies only, or even clinical variables of different sorts, there was some information there that could predict what would happen in response to therapy or in terms of stricture or fistula formation. But again, none of these are perfectly targeted for clinical utility. This is not good enough for clinical use. Even the combined model, you put all these things together, you only get to 0.69 when you put all these variables together. So still imperfect. One area which we do use to the extent that people are still using azathioprine, and I know my colleague on the stage, I think she couldn't tell you the last time she used azathioprine probably. However, if you do still use azathioprine, and it is used in much of the world, or mercaptopurine, then these two genetic polymorphisms are associated with the risk of myelosuppression. Thiopurine methyltransferase, which metabolizes thiopurines, and NUT15, which is encoding a Nutix hydrolase 15 and degrades thiopurine metabolites that are toxic. And these are things that you can and probably should measure before you start a patient on one of these medications. So that's in the here and now. So let's talk about an entirely different new mechanism of action, which is TL1A. So TL1A is a very interesting cytokine. TL1A and its receptor DR3, which is death receptor 3, are involved, as you see here, in many different immune pathways, all of which are implicated in the pathogenesis of IBD. And even more, if you look all the way on the lower right-hand side of this slide, you'll see that fibroblasts are in there as well. And so this pathway is implicated in fibrosis in many diseases, but certainly also in inflammatory bowel disease. Another thing that we can tell you is in GWAS studies, genetic genome-wide association studies, interestingly, it's not NOD2 that you see in Crohn's disease in Asian populations, it's TL1A polymorphisms. So this is implicated genetically, and that is a strong clue that this is important in IBD. So the first agent to target this is tulisokibart, and this was studied in the ARTEMIS-UC study. This was a phase 2 study, first of its kind for this mechanism of action. This is a very simple study in a way because it just simply randomized patients to tulisokibart or placebo. You see the regimen there, that's not important. And then the responders were re-randomized to one of two different doses, and the non-responders were given open-label tulisokibart. This is your standard moderate to severely active UC population in every way, except for the fact that actually they were quite severe. There were lots of patients with Mayo endoscopic subscores of 3. There were quite a few patients who had failed multiple advanced therapies, so a really, really sick population of patients. The other thing that was very interesting about this study that we don't show here is actually there were 2 cohorts, and the intention was to study a predictive biomarker that was thought to be associated with likelihood of response to the TL1A mechanism. There was a cohort 1 and a cohort 2. So what about the overall results? Well, first of all, as proof that this is a very sick population, look at that placebo clinical remission rate of 1%. That is absolutely the floor of response. That's how sick these patients were. But the patients who were treated with tulisokibart induction, you saw 26% achieve remission. So that's a delta treatment effect size of 25%. That's actually quite similar to what we see with upadacitinib. And at week 50, remember, they were re-randomized, the responders, to one of 2 different doses, and you can see that actually the higher dose did seem to do a little bit better. Endoscopic improvement, it's the same story. Clinical response, you see about 2/3 of patients achieving clinical response at week 12 and well maintained over the rest of the year. There were a bunch of other secondary outcomes, symptomatic remission, same story. Histologic improvement, so Marla talked about the coming target of histology in UC. Well, look, up to 70% of patients at the end of a year were able to achieve histologic improvement, assuming that they responded in the first place and were re-randomized. Histologic mucosal improvement, that's even more stringent because it's endoscopy and histology, and mucosal healing is just a deeper level of that. Half of patients are achieving kind of the ultimate outcome, perhaps, for ulcerative colitis at the end of a year. Now, I mentioned that predictive biomarker, and in cohort 1, which was the first analysis of that biomarker, it looked quite promising. There really did seem to be a strong differential in the clinical remission rate between those who had the biomarker and those who did not. Unfortunately, when the additional patients were recruited in cohort 2 and you put all the data together, the data still look good. The drug is still very effective, but the predictive biomarker had much less predictive value. That doesn't mean that we're done with predictive biomarkers, even for this mechanism of action, because there are many different kinds of biomarkers. They can be tuned in the laboratory in different ways to give you different properties. What about the safety? Well, of course, we don't have a lot of long-term safety, not tons and tons of patients, but at least so far this drug seems to be very safe. We don't see really broad immune suppression as we do with anti-TNFs. Really, we saw some COVID-19. Well, that's expected in this day and age, but really nothing unexpected here. Now, this was also looked at in a Crohn's study. This was the Apollo CD study. This was a little bit different because it was a Bayesian design, meaning it was a single-arm study with some comparison to reference a placebo rate. And same sort of deal, though, given treatment, induction period ends at week 12. And here the primary outcome was intentionally endoscopy because since it's a single-arm study, open label, this is an objective outcome, not patient-reported outcomes that could be biased by knowing that you're getting the drug. And then the patients were re-randomized if they responded and continued out through up to 170. Again, a sick population, multiple drug failures. How did they do? Endoscopic response, which means a 50% reduction from baseline in the SCSCD. That was achieved at week 12 in a little more than a quarter of patients. And basically at week 50, you can see that that's maintained with the higher dose. And clinical remission also was achieved at fairly high rates. If you look at key secondary endpoints, you can see endoscopic and clinical response or clinical remission together. So this is the combination of the two in the same patient. about 1 in 5 patients at the end of a year, biomarker in clinical response and or clinical remission in about a third. And we, of course, want patients to be corticosteroid-free if they're in clinical remission. That's also about a third of patients at the end of the year. So it really looks clear that this drug works well for ulcerative colitis and for Crohn's disease, although this is not a placebo-controlled study. Again, safety, no new messages here in terms of the safety. And this is not the only agent coming along to target TL1A. So if it were one drug, you might think it's just a fluke. But we have now 2 other drugs targeting TL1A that actually demonstrate clear efficacy activity for both UC and Crohn's. So this one is afimkibart. You can see that this study included an induction period, 3 different doses. Here the drug is given sub-Q, whereas tulisokibart was loaded IV and then sub-Q. And then there's a maintenance period. Placebo patients were re-randomized to 50, 150, or 450 every 4 weeks sub-Q. Those who were on 50 continued on 50. Those who were on 150 got 50 or 150. Those who were on 450 could have been randomized to continue on the same dose or drop to one of the 2 lower doses. Conventional kinds of primary endpoints, clinical remission by total Mayo score, in this case for ulcerative colitis, and pushed out a little bit to week 14, but otherwise very similar. And here you see the primary endpoint, which is clinical remission at week 14. There's a somewhat higher placebo clinical remission rate by total Mayo score. It's almost the same by the modified Mayo score on the right. But again, it's a very similar effect size, and it really looks like this agent also works. If you look at what happened as they panned out over week 56, depending on the different maintenance doses they were assigned to, it really kind of looks like all the maintenance doses work more or less to the same extent. I don't believe that the middle dose of 150 is any better or worse than anything else. They look the same. What about rates of endoscopic improvement? Same deal. You see an effect size of more than 20% across the board. And it didn't seem to matter, at the end of a year. Again, they all looked quite similar. What about the safety? It's the same message. This blocking TL1A does not seem to be broadly immune suppressing. Nothing very concerning coming out of the safety profile here. Now, the third agent, duvakitug, this was studied in a very interesting way because this is one of the few studies that have combined patients with UC or Crohn's disease in the same protocol, although they were analyzed separately. So this is a platform study. It's called a basket study, basket trial. So all these patients got a sub-Q loading dose and high dose, a low dose, or placebo, 40 patients each in UC and Crohn's disease. The primary endpoint was out to, I think, week 14, and then there was a long-term extension trial. Very typical kind of study, except for the basket design. On the left-hand side, you see the UC cohort with the primary efficacy outcome of clinical remission. Again, you see for the highest dose of 900 milligrams, there's an effect size very similar to what you saw with the others, 27%. This is a very high placebo clinical remission rate of 20%, and yet you still see clearly the efficacy of the drug. And on the right-hand side, they're looking at endoscopic response as the primary outcome, and it really does look like the higher dose is superior to the 450 milligram dose, and that is a whopping effect size of 35% for endoscopic response over placebo. So it looks quite good. What about secondary outcomes? Clinical remission in the experienced versus the naive. You see a little bit of a decrease in the absolute efficacy in the experienced patients, but if you compare it to placebo, the treatment effect size is the same, if not actually better. And on the right-hand side, in the endoscopic response in the Crohn's cohort, again, it's the same sort of message. Actually experienced, the effect size looks even better, and actually the absolute efficacy in terms of endoscopic response exactly matches what you see in naive. So not much drop-off regardless of your prior treatment experience. So very important. What does the safety look like? Once again, very typical things that you would see in an IBD trial. Nothing really very new, nothing very concerning or shocking. So there's a foot race on. All these agents are racing to the finish line. You can see it's going to be a few years before we see these in the clinic. It'll be interesting to see how the biomarker, predictive biomarker story develops along the way too. But you can see many are in phase 2 and some are already launching in phase 3, racing ahead, each one trying to beat the other to the finish line. But they all seem to be effective, so I think we're going to have an important new tool in our hands very soon. So I think we get back to the case here, and I'm going to turn it back to Marla.
Thank you. All right, so follow-up. This is Mark, who's, you know his story, right? And so diagnosed 2 years ago, requiring prednisone, was switched to vedolizumab. So that's what we did. We moved into vedolizumab. You talked
Perfectly fine choice.
Yeah, you talked about that choice. He's now presenting. His CRP is normalized, essentially. Sed rate's mildly still up. Calpro has come down, 50% almost reduction. He reports some mild improvement in stool frequency and rectal bleeding, so it's still there. He still has occasional urgency, needing some rectal therapy to control his symptoms. So what would you say to this? I mean, this patient is now 4 months on vedolizumab. You said that you would be scoping maybe 4 to 6 months. Would that matter? Do you need to scope someone who's got some urgency, whose calpro is still elevated, who's got some, still a little bit of rectal bleeding? What would you say at this point?
My answer may be different from yours, but I would scope because I want to understand what actually happened. He could still be very symptomatic and have a fecal calprotectin of 453, but it's entirely possible that he's healed a good portion of his left-sided colitis and maybe has residual just a little bit of proctitis that maybe with a little topical I could treat. I know you're going to say that you would not because he clearly has failed. I'd do an intestinal ultrasound and then I'd move on.
He knows my script already. We've done this a few times, but yeah. No, I mean, the point is that just to add a little bit on the IOS, Bruce is right, is that just remember one caveat with an intestinal ultrasound, we can't see the rectum because we're really front abdomen, and you could see the sigmoid quite low. So my response to Bruce would be if the ultrasound is normal, from what we can see, we know that it must be coming from the rectum, conversely, as opposed to. But again, I don't think it's really what your practice of treat to target is and how you utilize the various tools. So let's say you scope him and he's got still, maybe a little bit of Mayo 2 in the rectum, Mayo 1 in the sig and descending compared to Mayo 2 that he had before, just playing out the scenario. What would you do at this time? He's on vedolizumab. He's on standard dose of Q8. So really this is the big question about you've now targeted, right? You've treated a target. You've assessed interim the target, depending on which one we want to look at. And now you've got to make a treatment decision. What do you do next?
I think this is not good enough. So one choice might be to try to intensify therapy, move to every 4 weeks. You could measure levels. We have some vague idea of what therapeutic levels are for vedolizumab. But mostly, actually, we do have data about dose escalation and kind of partial responders from the ENACT study that was done very nicely by Andres Urur, and it doesn't seem to matter much if you dose escalate, even though we all often do it. I think I would just move on because we have so many other choices available.
So 4 months is okay, because a lot of us are not sure when to give up, So I'd venture that, remember in Europe, I'm not sure if Q4 is in the label, but pretty standard for them is to do Q4 vedolizumab. I mean, that's sort of a more standard approach. For us, you're right. You're saying, why fight for Q4 when we have other options? Is that your sort of summary here of this particular
More and
case?
more, that's how I feel because we have other choices available.
Okay. Would this be a candidate, based on the study, on the data we just saw, if we were to have TL1A, and then there's amazing questions, so I definitely want to get right to those because it does apply to what this question is what is the right patient? And based on the data, can we say much? Like if you had a patient like Mark who was on Vedo, based on what we see so far across the 3 the 3 targets that you showed us, would this be a patient if TL1A was available today?
Well, assuming the safety profile holds up, the efficacy is very good. Again, it looks almost like upadacitinib does. And so, yes, I do think this could be appropriate for this patient.
Because there's a lot of questions about where to position it, so this kind of we'll get into that in just a minute. I mean, the first question I'm going to ask is like really biologically so fascinating. So part of what you showed is the fibroblast we've not been shown the fibroblast when we've looked at all our all the targets since 1998, that cell has not been a highlight. It's been just cytokine focused on T cells and getting all the getting all those cytokines out of play in the serum or at the tissue. Can you tell us a little bit about what the implications of this class and its effect possibly on fibroblasts? And will it reverse fibrosis, or how are you thinking about it based on what you know so far?
Well, fibroblasts are evil. They do bad things. They can misbehave. And, obviously we're very concerned about fibrosis and Crohn's disease, where some proportion of our patients, maybe a third or so, will develop stricturing disease, and that's often a complication that leads to surgery. So one question is whether this might be a therapy that actually could reverse fibrosis or prevent fibrosis with early treatment. And I think the latter is where I really hope it will work, because we have this feeling that even with our most effective therapies, even with anti-TNFs, we still see some patients who do progress to fibrotic stricture. And we're also kind of ignoring the fact that with chronic inflammation in UC, there is elaboration of fibrosis as well. That leads to lead pipe colon, lots of other problems. And this is quite apart from all the other biology related to inflammatory fibroblasts, which are sort of implicated in kind of a evil axis with aggressive macrophages that sort of sustains the prolongation of inflammation. Yeah, so there are a lot of reasons to believe that addressing fibroblasts.
I think that, particularly, I'm more focused and thought more about, having grown up at Cedars and been all in on sort of this idea of precision and biomarkers, is to say that in Crohn's disease, particularly, if the biggest problem we face is people still progress to fibrosis and maybe have it typically often when they present, but just overwhelmed by inflammation, that balance between what's fibrotic and what's inflammation, we don't know until we give the anti-inflammatory. So the question is, yes, less in the animal models where they reversed, a mouse colon that looks different and is different than human, but the ability to say that we're finally sort of addressing maybe the cells that are involved in muscle hypertrophy and collagen deposition in the submucosa, I think that's exciting. One question, in the phase 3, any of the TL1As, is there a biomarker-driven arm, or have we wiped out biomarkers from our phase 3 designs?
Oh, in their study designs, I don't know that all the study designs are public information, but I still think there's a lot of excitement about biomarkers for this particular class of agents, so I think we'll see this studied regardless.
All right. So what about outside the gut? We've got up to 50% of patients over time, over a decade, recent studies suggest, have one or either an EI extraintestinal manifestation or a co-IMID or inflammatory or immune disease. What's the role of TL1A? Do you view that may be helpful in other inflammatory diseases?
It certainly may be. I mean, this is not a purely gut-directed therapy. There are lots of other conditions, immune-mediated conditions for which this could help. I don't think we yet know the full spectrum, because these studies in IBD are really the very first indication for the anti-TL1As. You're going to see a raft of other indications that will be explored, and then we'll know more.
And so also probably one of the big questions that a lot of folks ask as we go on is, do we accept monotherapy anymore? We have a therapeutic ceiling. You showed some great stuff, no doubt, but we still have a therapeutic ceiling in phase 3s in particular. We've seen the phase 2. So is this a drug that could do well in combination, and is that being studied at any level?
I think this is a drug that could be useful in a combination, but I don't know to what degree it is being studied in these early studies. Often drug development focuses on monotherapy. That doesn't mean that it couldn't move quickly to combination therapy. Please don't ask me what the best combination is, because I don't think anyone knows.
And last question, which I think is so important, is we've got so many. So we've finally got a break, because we've had so many new like IL-23 explosion. So soon we have to prepare ourselves for the TL1A explosion.
Oh, yes,
okay.
That's clear.
So that's our next, where we're going to be speaking a lot. And probably the question that has come up the most, is there still a role for anti-TNF therapy in IBD? Last question. Drop the mic moment.
At this moment, there is. Will there be if TL1As hold up to their promise? There's so much we have to learn about fistulizing disease, effects on strictures. If the promise holds up, then we might be not really using anti-TNFs in the future.
All right.
That's speculation.
So that's your speculation.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an independent educational grant from Merck Co, Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/WVY860.